Good evening and welcome to Doctors on Call. Tonight we're answering your questions about everything from Alzheimer's disease to chronic migraines to the treatment of strokes and other neurologic problems. I'm Dr. Alan Johns from the Department of Family Medicine and Community Health at the University of Minnesota Medical School Duluth. I'm your host tonight. I'm pleased to welcome our panelists. Dr. Vik Jadhav, a neurologist with Essentia Health. Dr. Samuel Laney, a physical medicine and rehabilitation specialist with St. Luke's Medicine and Rehabilitation Associates. And Dr. Ken Ripp, a family medicine physician with the Raiter Clinic in Cloquet. We'll be taking your questions at 218-788-2844 or toll free at 1-877-307-8762. Our medical students answering phones tonight are Ben Harris from Stewartville, Minnesota, Paige Selvey of Eagle Bend, Minnesota, and Courtney Tussler from Brainerd, Minnesota. Now on to our program, Stroke and Other Neurologic Problems. Well, Dr. Vik, in the old days, a stroke was a stroke. People would come in and you'd take your time and you'd try to figure out what's going on, and there wasn't a lot we could do for them. There's something like it's called a stroke attack now, somewhat like a heart attack. It's a whole new urgency to treating strokes. Is that right?
That is correct. And in fact, in the last 2 years or so, there have been rapid and remarkable advancements in the field of stroke and treatment for stroke. And recently, there have been a spate of clinical trials conducted all over the world, including the United States, which have shown that if the patient comes to the ER and to the hospital within a certain time window, then we can actually administer stroke treatment by giving them clot-busting medications. And at the same time, we can actually use advanced treatment by putting a catheter in and retrieving the clot from the blood vessel that is occluded.
Oh, so you pull the clot right out?
Yes,
there.
we can pull the clot out. And these are really good and advanced treatments that can be offered to all our patients over here.
What is this stroke window? Are we talking an hour or two, or?
No, actually, it's not as less as hour and two. If the patient comes within the first 4.5 hours, you can give, from the time the symptoms have started, then you can give the patient a clot-busting medication to break up the clot. And if you can get to the patient within 6 to 8 hours, then you can actually advance a catheter through the groin and go to the vessel that is blocked because of the clot and retrieve the clot out. Now, depending on the size of the location of the stroke, the window can be expanded a little bit, because strokes that happen in the back of the head, where the blood vessels are supplying important areas that are responsible for breathing and controlling the respiration of a patient, in that case, the therapeutic window is much longer, because those strokes, they tend to be more disastrous in outcomes. So we can actually try and provide more treatment to those patients, take more risks.
Well, thank you. Well, Dr. Laney, we have a caller already. We have 2 calls in really fast here. A caller from Duluth would like to know SPECT scans, PET scans. Do we have them in Duluth, and what's the difference between them?
Well, a PET scan, fascinatingly, the P stands for positron. So if you've ever wondered whether antimatter is real, it actually is. It's my understanding that they label a glucose with this tracer, which is the positron. And then they can see where, for instance, in the brain, they might be looking for a tumor. They might be asking, oh, okay, we see a mass in the brain. Is it a metabolically active tumor? And so if that part of if this mass is seeming to use a lot of this sugar, they say, yes, it's metabolically active. The SPECT scan I'm not as familiar with. Perhaps Dr. Vik?
Dr. Vik, how about a SPECT scan?
I'm not sure whether we have those over here, but again, as you elaborated, they are scans that can be done to actually focus on tissue that is more metabolically active, so as to differentiate from the other normal tissue.
Thank you. Interesting. Well, Dr. Ripp, we're to you now. Now let's get back to, okay, we've been talking about strokes, but what kind of symptoms would you see? You know, we need to get people to the ER, but people at home, what are they looking for in their loved one who's having a stroke?
Well, anyone who's having, the classic stroke would be someone who's lost use on one half of their body. They may have difficulty with speech, function in the hand, so they might, see a facial droop, and those would be the major symptoms. Sometimes people the other type of stroke we've talked about, ischemic stroke, but a hemorrhagic stroke often can present with just a severe headache, and those can be profound.
Thank you. Dr. Vik, a caller from Barnum would like to know for treatments for cervical dystonia, or maybe Dr. Laney, either of you.
Sure.
Please.
So, as the caller has elaborated, cervical dystonias, these are just abnormalities in the way the muscle contracts. So the patient, they can experience pain and spasms because of this. And for this, we have some treatments which could range from Botox injections to something that can decrease the spasm of the muscle and kind of relax the muscle. But I'll let Dr. Laney elaborate more on that.
Yeah, I think in the past they used to call these torticollis or wry neck. Frequently a person will have a flexed neck or a twisted neck, and they can't make the muscle involved quiet down. I think that we've learned that most of these come from the basal ganglia. You see the muscle on the outside, but in fact they're a form of a movement disorder. In general, they've tried deep brain stimulation for some of them, but it's not routinely done. And that's inserting electrodes to certain parts of the brain to stimulate neurotransmitter release. This is sometimes effective for Parkinson's, another movement disorder. But generally still with this torticollis or cervical dystonia, you just go to the muscle and try to carefully administer enough Botox to relax the muscle without leaving the person with a droopy head.
Okay, thank you. We have another caller from Duluth wondering about, now this is a common topic now, concussions, Dr. Ripp. See a lot of concussions or post-concussion problems?
Yes, a lot anywhere from young kids to adults. It's gotten a lot of attention now with athletes, both with the football and the NFL and their issues with post-concussive syndromes with the adults. But for the kids, it's been the state's mandated certain procedures be done to allow kids back, which I think is very helpful. Concussions are dangerous. You can't get that IQ back that you lose if you are severely concussed. The biggest thing is allowing the process to go through to let those kids recover and be without symptoms for quite a period of time before you allow them back to full contact sport. Kids are anxious, they want to get right back out there, and the coaches want their best players back out, but a lot of times it's being patient, letting the process go through and letting that kid heal up.
What kind of symptoms do people have after a concussion? Not the in the first minute or two, but
usually, most commonly kids will have headache. The light and sounds will bother them. Their appetite will be off. They just won't feel right. And I had one, varsity hockey player who quit the sport, said, I would rather break my legs than get another concussion, on what it did to him mentally and academically. He was a bright kid, and he was smart enough, and he is in college now and he's pre-med, and he says, and I never forgot that statement that he made, because he said, this is devastating to me every time I get a hit and I'm concussed.
Wow.
I think that brings up a good point, that the person may seem to recover from the concussion, but later they may have subtle problems, and they may not raise their hand and say, I'm struggling. But if you're talking about a pediatric patient, the parents should watch for this. They should watch for school performance changes, and the physicians should kind of come around those types of patients and make sure that they don't struggle without help.
Yeah, I agree. The subtle problems could be just very mild cognitive deficits, some things that the patient has been used to doing, and then suddenly over time they are not able to do it. For example, if they are driving to the grocery store and picking up some things, maybe 6 months after repeated concussions, they may not be able to do that as effectively. And usually these things are missed unless they actually get into an accident or something really bad happens, and then suddenly people start realizing, oh, this was because of these concussions that he has had in the past.
Interesting. Thank you. Well, Dr. Vik, a caller from Duluth would like to know about Tay-Sachs disease. Like what symptoms and what is it?
Well, these are what I would say enzyme disorders, I would say, and the symptoms could be wide-ranging because it could be involving a lot of systems, a lot of organs could be involved. But if I recall right, I think one of them could be the retinal, the red spot in the retina. So vision problems could be a problem, and then also it could also involve the other organs, maybe like the heart and other stuff too.
So are there neurological issues associated with it then, other than the eyes?
I believe there are. I don't think I've ever taken care of a Tay-Sachs patient. I believe it's an inherited problem with an enzyme where a substance builds up instead of being processed and eliminated from the body, and it can build up neurologically. I think it's particular to certain ethnic groups. So maybe if you practice in a big coastal city where there are such populations, you see more of it.
Okay.
I wouldn't be surprised if we don't see it here in Duluth. But yeah, there are neurologic sequelae.
Thank you. Very good. Well, Dr. Laney, a caller, this is one question I wanted to ask, and she asked it for me. A caller from Cloquet. A person who's had a stroke, are they going to get better?
Generally, yes. If you look at a lot of stroke patients, they frequently improve a lot. In fact, some of them, I've been doing this for a while, and some people still really surprise me and do much better than I thought they would. The general way to look at this is that after the stroke, there's a certain, there are areas of the brain affected, and you can see that in terms of function. Maybe one side is weak, or the patient cannot find the right words to express herself. So what happens then? Well, in the aftermath of that, the neurons that are still surviving, and there are usually a lot of neurons still alive, or the patient would be doing even more poorly. Those neurons change the way they interact with each other. They beg each other to reach out and form new connections.
Kind of get rewired.
Rewiring. Now, the general term for this is neuroplasticity. And we feel that this neuroplasticity drive is particularly strong after stroke for about a 3-month period. And then it tapers off, but it doesn't quit for at least a year. Some people say a year and a half. So we are keen to see some evidence of, say, an arm start to work within 3 months. If it does, then we have reason to be hopeful that it will continue improving and maybe get back close to where it was. And we also tell people, if they ask, Doc, my arm doesn't work, what will I get back? We say it'll take you a year to find out. And we think that's good news because we're saying to the patient that your brain is going to keep trying to heal itself for a year. Then one other issue is that, let's say the arm doesn't come all the way back, but the patient learns how to do his buttons or tie his shoes with one hand. Well, then he has also gotten better. He's gotten more functional, but through compensation. Sure. So there are those avenues to sort of regain your life and your function. And generally, we see substantial improvement in stroke survivors.
Oh, thank you.
The curve is very, a lot of times you can have people get much better rapidly. But then, I agree, but even later on, because I have the privilege of seeing people over decades, and I have had stroke patients who've come in 12 years later and say, look, I can now, even years out, they've worked at it and gotten a little more function back years after their event, in which I'm excited for them. And a lot of it is the will of the patient.
Interesting.
If they, still try and use that hand, force it to work, it is amazing what the brain can do.
Thank you. Well, Dr. Ripp, I think this is the next question would go to you. A patient, it's a question is about when do you get CAT scans, when do you get MRIs, And why get a CAT scan with dye or not? I mean, it's kind of a general question. It depends.
So CAT scans are great. They're widely available. They're quick. They especially see blood. Like, so if you had a head injury or if you had an acute stroke and you want to rule out that they're not having a bleed in their brain, because the medicines that we use to treat stroke sometimes, if there is any bleeding, will make that much, much worse. So you have to know that piece of information. MRIs give a much more detailed picture of the tissue, and so actually if you're within 24 hours of stroke, if you can get an MRI, the MRI will actually show the detail of the brain better, and you can actually see a stroke better on an MRI than a CT. MRI is not available 24 hours a day, 7 days a week in most facilities. And so with and without contrast, it helps us to understand if you're looking for a tumor or other, it can help delineate other structures. Most of the time we're just doing for acutely, we're just doing a one without contrast to see what's going on.
Well, thank you. There's a caller from Duluth, Dr. Vik, who writes and says, why are anticoagulants contraindicated in a stroke?
Okay. So anticoagulants are the class of medications that we do come across, like warfarin, Coumadin. That's the commonly known anticoagulant. So when a patient has a stroke, previously, maybe like 20 years ago, these used to be the frontline medications. We used to start patients on anticoagulation, but now we have evidence to show that actually this is not beneficial, and we actually treat the patients with clot-busting medication called alteplase. So when the patient comes within the therapeutic window that we just spoke about, then we can give the clot-busting medication, and then the clot can disintegrate, and then the blood flow to the brain is restored. Now, if the patients are not within the therapeutic window, you can give other kinds of medication called antiplatelet medication that prevent the platelets from aggregating. These are small cells within the blood, and these are aspirin and Plavix, or aspirin and clopidogrel. These are the medications that can be used. Now, interestingly, we can give anticoagulants, but we usually start them in patients who have a certain kind of stroke. So for patients who have an abnormal rhythm of the heart called atrial fibrillation, so in those patients, the clot can come from the heart, and unfortunately, if it gets into the blood vessel that goes to the brain, then the patient experiences or has stroke symptoms and gets a stroke. So in those patients, we can put the patients on anticoagulation, because that will thin out the blood and decrease the chances of a clot going from the heart to the brain and causing stroke. But the timing of that is decided by the doctor depending on the size of the stroke and other factors.
I think this speaks to his point about the timeliness of getting to a stroke team and getting the proper scan. Is we should mention that there are strokes which are hemorrhagic, they are bleeding type strokes. And then there are ischemic strokes, which we would say those are clots. You need to know that right away, because it very much changes the treatment of the stroke.
Yeah, I believe the caller probably was alluding to that point. So as you rightly pointed out, get the CT scan, find out whether it is a bleeding or an ischemic kind of a stroke, because in a bleeding kind of a stroke, you would never give anticoagulants, because that's actually going to worsen the bleeding.
Thank you. We have a caller from Dr. Laney. We have a caller wondering about Guillain-Barré syndrome. Very interesting condition. What causes that? Do people know what the cause of that is? And better, more importantly, what's the prognosis of Guillain-Barré?
So Guillain-Barré is what we call a demyelinating disease. And the Guillain-Barré hits what we call the peripheral nervous system. So just for point of reference, there's a central nervous system, brain, spinal cord, optic nerves. And then there's a peripheral nervous system, the nerves that come out of the spine, like the sciatic nerve or the sensory or motor nerves in the arms. Multiple sclerosis is a demyelinating disease of the central nervous system. Guillain-Barré is a demyelinating disease of the peripheral nervous system. Classically, it is triggered by a viral illness. These are fascinating subjects that we could talk about a lot, but somehow some illnesses seem to be able to trick the immune system into recognizing some part of the body as something that it should attack. Another example of that kind of thing is the way rheumatic fever sometimes tricks the immune system into attacking a heart valve. So the classic thing with Guillain-Barré is a person has some sort of illness, and they probably recover from it. Then later they get what we call an ascending paralysis. They start to feel weak in the feet, and then this goes up higher and higher. It may go so high and be so severe that the diaphragm is paralyzed, and without ventilation, being on a ventilator, the patient could expire. You can do things to try to wash out those harmful antibodies. You can give high doses of steroids. Most people recover. Not everybody recovers all the way. In general, the prognosis for Guillain-Barré is actually quite good.
Good. Thank you. Dr. Ripp, a caller from Hermantown would like to know about preventive medications for migraines. Migraines, headaches, we haven't gotten into that, and we just have a few minutes left.
There's a long list of medications. So if you're having migraines that are disabling more than 1 or 2 days a month, or having headaches that are happening more than 2 or 3 times a week, then preventive medicines could be helpful for doing that. There's several classes. We use some of the seizure medicines. We use some antihypertensive medicines. There are, I'm just trying to think of some others. Sometimes certain, some people respond to magnesium supplementation. So they can be very helpful at lowering the number and frequency of the headaches and the severity. You're not going to eliminate them all. And you're trying to bring that number down so that when you use the medicines to get rid of the therapy, get rid of the migraine, we call abortive therapy, you need to use that less often. Mm-hmm. And so that's our goal, is not to eliminate all the headaches, which is great if we can, but lower the number and severity. So.
Thank you. Dr. Vik, we just have a couple of minutes left. Dr. Vik, a caller from Duluth would like to know about if you had a stroke, or this maybe a stroke in the thalamus, are you at risk for a second stroke? I mean, well, how often do second strokes happen?
Yes, you are at a risk for a second stroke based on the etiology of the stroke. What I mean by that is strokes can happen because of multiple reasons. One of the reasons we discussed was coming from the heart. The ones that can occur in the thalamus, those tend to be the strokes that happen because of disease in the smaller blood vessels, and those tend to be because of uncontrolled blood pressure and increased cholesterol. So those are and if the patient is a long-term smoker, so these are the things that need to be controlled. So if you can control these, then obviously the risk for future strokes are going to be diminished.
Thank you very much. And finally, I think probably one of our last questions, Dr. Laney, a caller from International Falls, had a brainstem stroke. She is still able to breathe, however. I guess the question is, would brainstem strokes, they can be mild or severe, or what's the range there?
Yeah, so the brainstem is a very old part of the brain that has to do with a lot of different functions in the body, including what we call cranial nerves, have to do with control of the face, has to do with how your eyes and your ears work together for balance. The classic thing with a brainstem stroke is what we call cross deficits, maybe numbness on one side of the face and weakness on the other shoulder. That would make a neurologist think brainstem. Another classic thing with brainstem is nausea, because if your senses, your eyes, your ears, things like that, if they don't all give you the same information, the body reacts with nausea. So what I'm used to seeing with brainstem strokes is this nausea, this just not feeling right, frequently a difficulty with what we call finding midline. You tell a patient to sit up straight and they lean, and typically they show steady improvement. They don't get better overnight. Long term, they tend to do pretty well.
Oh, well, thank you very much. And finally, controlling blood pressure, diabetes, smoking, big things, right?
Oh,
very
huge.
important.
Yep. Exercise. if you've had a stroke, there are other medicines. There's acute medicines and there's chronic medicines that we like to see people on for the rest of their life. Certain blood pressure medicines, diuretics, cholesterol medicines to help prevent that next stroke. That's our best hope in controlling their other diseases.
Well, thank you. So I'd like to thank our panelists, Dr. Vik Jadhav, Dr. Samuel Laney, and Dr. Ken Ripp, and our medical student volunteers, Ben Harris, Paige Selvey, and Courtney Tussler. Please join Dr. Ruth Wester next week for a program on diabetes when her panelists will be Dr. Gail Baldwin, Dr. Ryan Harden, and Dr. Nahi Kablawi. Thank you for watching and good night.